Let's start 30-minute session of today's reading USMLE first aid. Okay, yesterday we read till calcitonin. Okay, let's start from glucagon, source made by alpha cells of pancreas. Function promotes glycogenolysis, gluconeogenesis, lipolysis, ketogenesis. Elevates blood sugar levels to maintain homeostasis when blood stream glucose level falls too low, that is fasting state. Regulation secreted in response to hypoglycemia inhibited by insulin, amylin, somatostatin, hyperglycemia. Yes, we know all of this. Just to remember and connect all the dots to have a conceptual understanding, we'll repeat it again. Glucagon source is alpha cells of pancreas. First point. Function, it promotes glycogenolysis, breakdown of glycogen. Gluconeogenesis, synthesis of glucose from other substrate. Lipolysis, breakdown of fat. Ketogenesis, elevate blood sugar levels to maintain homeostasis when bloodstream glucose falls too low, that is fasting state. Yes, we know this. Secreted in response to hypoglycemia inhibited by insulin, amylin, somatostatin, hyperglycemia. Yes. Next, about insulin. Pre-proinsulin synthesized in rough endoplasmic reticulum of beta cells. Oh, we read these two yesterday. We read glucagon and insulin both. We read adrenal steroids and congenital adrenal hyperplasias also. We read cortisol too, or not? No, we didn't read cortisol. So let's start with cortisol. Cortisol source adrenal zona fasciculata. Okay, zona fasciculata binds to corticosteroid binding globulin. Okay. Function, increase appetite, increase blood pressure, upregulates alpha 1 receptor on arterioles, leads to increased sensitivity to norepinephrine and epinephrine permissive action. At high concentration can bind to mineralocorticoid aldosterone receptors. Increased insulin resistance, diabetogenic. Increased gluconeogenesis, lipolysis, proteolysis, that is decreased glucose utilization. Decreased fibroblast activity, poor hundeling, decreased collagen synthesis, increases striae. Decreases inflammatory and immune response. Inhibit production of leukotrienes and prostaglandins. Inhibit WBC adhesion, leads to neutrophilia. Block histamine release from mast cells. Eosinopenia, lymphopenia, blocks IL-2 production. Decreased bone formation, that is decreased osteoblast activity. Cortisol is a big FIB. Exogenous glucocorticoid can cause reactivation of TB and candidiasis. Blocks IL-2 production. Stress circadian rhythm, stimulates hypothalamus. Hypothalamus in turn CRH stimulates anterior pituitary. Then anterior pituitary secretes MSH, melanocortin, converted into MSH, melanocyte stimulating hormone, adrenocorticotropic hormone, and endorphins. Adrenocorticotropic hormone acts on zona fasciculata of adrenal gland and it secretes cortisol. Cortisol in return act as feedback inhibition to hypothalamus if level of cortisol gets increased. Downstream cortisol function. Yes. So we are understanding now about cortisol hormone, its source, its function. In a diagrammatic flow chart, we are understanding its mechanism. Okay. Just read now regulation. CRH, hypothalamus, corticotropin releasing hormone, stimulates adrenocorticotropic hormone release from pituitary, leads to cortisol production in adrenal zona fasciculata. Excess cortisol decreases CRH, ACTH and cortisol secretion. Yes, we understood the same facts from this diagram they have given us. Chronic stress may induce prolonged cortisol secretion. Cortisol resistance, impaired immunocompetency, dysregulation of hypothalamus pituitary axis. Okay, we are understanding all the points. Just to make sure we understand all of the points again, we'll read again and move to the next topic. Source of cortisol, adrenal zona fasciculata. Function, increases appetite, increases blood pressure. How it increases blood pressure? By upregulates alpha 1 receptor or arterioles, increase sensitivity to norepinephrine and epinephrine permissive action. At high concentration can bind to mineralocorticoid aldosterone receptors. Oh, there are these two mechanisms of cortisol we have to keep in mind. How it can increase the blood pressure. Insulin resistance, diabetogenic, increases insulin resistance. Yes, because it increases appetite. Yes, and because it causes gluconeogenesis, lipolysis and proteolysis. That's why it's diabetogenic, insulin resistance. Decreased glucose utilization also. Decreased fibroblast activity, poor wound healing, decreased collagen synthesis, increased striae, decreased inflammatory and immune response, inhibit productions of leukotrienes and prostaglandins. This is the main important function. Inflammatory and immune response, inhibit the production of leukotrienes and prostaglandins. We know this. Inhibit WBC adhesions, neutrophilia, can lead to neutrophilia, block histamine release from mast cell. Eosinopenia, lymphopenia, blocks IL-2 production, decrease bone formation. That is osteoblast activity. Okay. Cortisol is a big fib. They have given mnemonic to remember all the points related to cortisol. Okay. Exogenous glucocorticoid can cause reactivation of TB and candidiasis because immune suppression. It blocks IL-2 productions. Okay. We understood the cortisol hormone. Next, move on to appetite regulation. Which hormones comes here? Ghrelin, leptin, endocannabinoids. Okay, let's start with ghrelin. Stimulates hunger, orexigenic effect, and growth hormone release via GH secretagogue receptor. Produced by stomach, sleep deprivation, fasting, or Prader-Willi syndrome. Increases ghrelin production. Ghrelin makes you grow hungry. Acts on lateral areas of hypothalamus, hunger center, to increase appetite. Okay, about ghrelin. Ghrelin stimulates hunger. That is called as orexigenic effect, and growth hormone release via growth hormone secretagogue receptor. Produced by stomach. Okay, ghrelin stimulates hunger and also releases growth hormone. The source is stomach. It can be get triggered by sleep deprivation, fasting, Prader-Willi syndrome. That all leads to increasing ghrelin production. Ghrelin makes you grow hungry. Okay. So they have highlighting some letters to make us understand what is its function. GHE for grow hungry and growth hormone. Okay, how it acts on lateral areas of hypothalamus, hunger center, to increase appetite. Got it. Next, leptin, satiety hormone produced by adipose tissue. Mutation of leptin gene leads to severe obesity. Obese people have increased leptin due to increased adipose tissue but are tolerant or resistant to leptin and orexigenic effect. Sleep deprivation or starvation leads to decreased leptin production. Leptin makes you thin. Act on ventromedial area of hypothalamus satiety center to decrease appetite. Okay, so it is a satiety hormone produced by adipose tissue. Mutation of leptin gene leads to severe obesity because we'll eat more. There is nothing to control the appetite. As this is what I'm understanding and connecting all the points for more knowledge. Obese people have increased leptin due to increased adipose tissue. Oh, but are tolerant or resistant to leptins and orexigenic effect. Okay, leptin is more in quantity, but it's not able to produce its result because it's tolerant to an non-oxygenic effect. Sleep deprivation or starvation leads to decrease in leptin production. Leptin keeps you thin, acts on ventromedial area of hypothalamus satiety center, that leads to decreased appetite. I am enjoying this reading again. First aid, I am able to connect all the points. Endocannabinoids act at cannabinoid receptor in hypothalamus and nucleus accumbens, two key brain areas for the homeostatic and hedonic control of food intake, that leads to increased appetite. Exogenous cannabinoids can cause the munchies. Okay, endocannabinoids act at cannabinoid receptor in hypothalamus and nucleus accumbens, two key brain areas for homeostatic and hedonic control of food intake. Okay. leads to increase in appetite. Exogenous cannabinoid can cause the munchies. Okay, got it. We understood the appetite regulation, ghrelin, leptin, and endocannabinoids. Basically, ghrelin increases hunger, leptin reduces it, endocannabinoids increases. It's like ghrelin, but by different mechanism, and it's externally consumed. Exogenous cannabinoid can cause munchies. Okay. Signaling pathways of endocrine hormones: CCAMP, CGMP, IP3, intracellular receptors, receptor tyrosine kinase, non-receptor tyrosine kinase. Okay, signaling pathways of endocrine hormones: CCAMP, CGMP, IP3, intracellular receptor tyrosine kinase, nor receptor tyrosine kinase. How the signaling pathways work? CCAMP for FSH, LH, adrenocorticotropic hormone, thyroid stimulating hormone, corticotropic releasing hormone, hormone chorionic gonadotropin, antidiuretic hormone, VC2 receptor, melanocyte stimulating hormone, parathyroid hormone, calcitonin, histamine, H2 receptor, glucagon, growth hormone releasing hormone. All of these hormones act via CCAMP. Now GCAMP, brain natriuretic peptide, arterial natriuretic peptide, EDRF. Bad gram P, things vasodilation and diuresis. Okay. IP3, GnRH, oxytocin, ADH, TRH, histamine, angiotensin 2, gastrin, goat hack. Intracellular receptor: progesterone, estrogen, testosterone, cortisol, aldosterone, T3, T4, vitamin D. Receptor tyrosine kinase: IGF-1, FGF, PDGF, EGF, insulin, MAP kinase pathway. Get found in the MAP. Non-receptor tyrosine kinase: GCSF, erythropoietin, thrombopoietin, prolactin immunomodulator, that is cytokines, IL2, IL6, IFN, GH, growth hormone. Okay, all of this are very factual information. I have to revise again and again. Make sure I correlate this to clinical points for my practice as a clinician to solve MCQs. The end goal is to be a good clinician, or maybe even if I go in research, but I must have to have some purpose behind all of this learning. I must know where I am going to use this. I am not reading this just for reading sake or any other things. I am reading this with purpose to build my knowledge and to use that knowledge in application. And clearing an exam with good marks is going to be the byproduct. I know I have to be specifically study for the exam, but if I keep the main end goal in mind and strive for excellence, all of these things I am going to achieve for sure. I know this. Signaling pathways of steroid hormone. Okay, steroid hormones are lipophilic and therefore must circulate bound to specific binding globulins which increase their solubility. In males, increase hormone binding globulins lowers free testosterone, leads to gynecomastia. In females, SHBG, sex hormone binding globulin, raises free testosterone, leads to hirsutism. Increase in estrogen, that is OCP, pregnancy, increase sex hormone binding globulin. Okay. Steroid hormones are lipophilic, therefore must circulate bound to specific binding globulin, which increase their solubility. In males, increased sex hormone binding globulin lowers the free testosterone, that is gynecomastia. In females, decrease SHBG, raise free testosterone, leads to hirsutism, so it acts opposite. Increased testosterone, that is OCP, pregnancy, leads to increase in SHBG. Got it? Okay, now binding to receptor so let's read this diagram they have given to us to understand the mechanism, to understand the pathway. Binding to receptor located in nucleus or in a cytoplasm. H is hormone, R is receptor. Okay, binding to receptor located in nucleus or in cytoplasm. Okay. Transformation of receptor to expose DNA binding protein. First, this is binding to cytoplasmic receptor. Then the complex goes inside the nucleus, binding to enhancers like element in DNA. Okay. Intron, exon, pre-mRNA, mRNA, nucleus, that is ribosome protein response. Okay. So this is how the pathway is. We'll repeat once again just to lock in this as a conceptual information and pictorial information in our mind to recollect it better. Hormone binding to receptor located in nucleus or cytoplasm, whichever it may be. Then transformation of the receptor to expose DNA binding protein. Okay, binding to enhancers like elements in DNA. Then gene, intron, exons are there. mRNA that leads to mRNA, from mRNA to ribosomes to synthesis of protein. That protein synthesis comes out of that cell, that nucleus, leads to response. Got it? How much time we are reading now? For 18 minutes we are reading. More 12 minutes to go. Okay, endocrine pathology. Next subtopic we are reached. Syndrome of inappropriate antidiuretic hormone secretion. So let's read the information they have given on the right side of mine. So viewers also the right side only. Characterized by excessive free water retention. Antidiuretic hormone, right? Which means what we understand from the antidiuretic hormone is antidiuretic. Diuretic means going in urine. So anti, opposite of going in urine, water going in urine. What is the opposite of water going in urine? Is water retention. We got it. So that's what they have given, characterized by excessive free water retention, euvolumic hyponatremia with continued urinary sodium excretion. Urine osmolarity increases, serum osmolarity decreases. Yes, this makes sense because body has to lose all the sodium because its water is getting filled. And how to get water out of body? We have to excrete sodium, so what, in hope that water will follow it, but it doesn't. So that's why we lose the serum osmolarity and increase in urine osmolarity, which means in simple word, in urine we'll find more sodium. Body responds to water retention with decreased responds to water retention. How body responds now? It has to uh, decrease the hormone which is causing it, that is lowers the aldosterone, increases arterial natriuretic peptide and brain natriuretic peptide, which leads to urinary sodium secretion, increases urinary sodium secretion, normalization of extracellular fluid volume, euvolemic hyponatremia. Okay, treatment fluid restriction first line. So if we have more antidiuretic hormone secretion, the syndrome of inappropriate antidiuretic hormone secretion, what we have to do? We have to restrict the fluid as a first line. No source of fluid coming in, then where the retention of, where the water will come for retention? So that makes sense. So that is the first line. We have to reduce the fluid restriction. Salt tablets, yes, we have to prescribe the salt, or we have to take salt as we are losing salt. IV hypertonic saline, diuretics, yes, ADH, IV hypertonic saline can cause diuresis, for my understanding, because there will be more uh, electrolytes in that, so body may respond to neutralize it. Salt, yes, the same again. I diuretics, yes, basically to clear out the water, not retention. ADH antagonist, yes, makes sense. Covitan, tolvaptan, demeclocycline. SIADH, syndrome of inappropriate diuretic hormone secretion. Causes include HEELD, upwater, H, head trauma, CNS disorders, E, ectopic ADH, that is small cell cancer, E, exogenous hormone, that is vasopressin, desmopressin, oxytocin, L, lung disease, D, drugs, SSRI, carbamazepine, cyclophosphamide. SIADH include HEELD, upwater, head trauma, if some head trauma is there, CNS disorder, ectopic ADH secretion, just for example, in small cell lung cancer, exogenous hormones, SIDH. Okay, SIADH causes. Yes, we are completing our 30 minutes. We started at 12:15, right? No, 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 12:15. It's 12:45 almost. So we'll cover the syndrome of inappropriate antidiuretic hormone. We'll call it a day, and we'll sleep nicely. Although I know I have, but we'll not talk about that in this session. Uh, In this session, our goal is to read USMLE first aid, and we are doing that. I know we are doing minimum 30 minutes. Our goal is to read 45 minutes to 1 hour every day. If not, at least minimum 30 minutes has to be there, and we are achieving that consistently by day 2. In the day 1 was yesterday or day before yesterday. I don't know, so I'm forgetting a little. I guess yesterday we did 3 sessions. No. So first day we did 2 sessions. One first was private, second was public. Yesterday we did 1 session that was public. Today is our 3rd public session and 4th session in total. Okay, got it. So we have almost. We'll just look at this diagram and we'll call it a session. Minimum. We have to increase the number of sessions. We'll work on it, but minimum we are doing right now. So just focus and call it a session. Just read this diagram once. Hypothalamus. Okay. Secretes antidiuretic hormone in posterior pituitary where it gets stored. Okay, from posterior pituitary, antidiuretic hormone acts on medullary connecting duct aquaporine channel. It is a syndrome of inappropriate antidiuretic hormone secretion, stimulates more ADH. ADH antagonist lithium neprogenic DI inhibit ADH. Okay. Now, it leads to increased urine osmolality, decreased urine. What we have read in the text, that is in the pictorial form. So this is nice. This helping us build our concept, build this image of this concept in our mind. So this is helping a lot. So negative feedback, how? By increase in serum osmolality, if it increases, means more sodium in our blood, it gets triggers hypothalamus. It is positive feedback, so more ADH will be secreted. Central diabetes insipidus, if there is more fluid in the body, it will act as negative feedback, as simple as that. So it will stop the antidiuretic hormone secretion. If there is decrease in osmolarity, less sodium in the body, or increases serum volume, then also there is negative feedback. There is a reduction in antidiuretic hormone synthesis. Got it, this concept, and we'll call it a session. What we have studied, just we'll see once. We started with cortisol. We understood cortisol. We understood appetite regulation, ghrelin, leptin, endocannabinoids. We understood signaling pathways of endocrine hormones. We read this, but to remember it, we have to revise it again and again, and put this chart in front of our eyes from time to time, just to have pictorial memory. So I understood the signaling pathways of steroid hormone, how the pathways is hormone receptor inside the nucleus, then ribosome, protein, and then the response. We understood the endocrine pathology, first topic, syndrome of inappropriate antidiuretic hormone secretion. In that way, saw the mechanism, build our conceptual understanding. So that's it for today session, and we'll end it. Good night, all of you, all the viewers, and we'll see you in the next session.